Welcome to Variations 4, the genitourinary unit. In this video, we're going to cover questions 1 to 3, starting to look at acute renal failure. First question asks us to look at pre, intra, and post-renal failure. So let's start by looking at a diagram here. So in essence, what is pre-renal failure? Pre-renal failure is basically anything that causes kidney dysfunction, wherein that cause is, I guess, from a circulatory point of view, preceding the kidneys. Can you think of an example? Dehydration is a huge example. We see this all the time in the hospital. It precedes the kidneys in that if you think of it top down, which is an okay way to conceptualize this, then someone has to drink fluids up here or even get an IV up here before it's going to reach the kidneys. That's just a pictorial way, a visual way of understanding the concept of pre-renal. Before it gets to the kidneys, it has to enter the system either by mouth or by IV. Then it gets into circulation, then it moves through the kidneys. So if circulation is low from a cause of dehydration or blood loss, that's going to cause kidney failure. And that cause is pre-renal because the cause was before the kidneys. So what's intra-renal failure? Anything that's happening within the kidneys, inside the kidneys. Could be an infection, could be cancer. Typically, there's some kind of inflammatory process, whether it's autoimmune or infective, viral, bacteria, whatever. Some kind of process in here, or it could be something they're born with, structural. But some kind of dysfunction inside the kidneys, and that's intrarenal. So finally, what's post-renal failure then? Anything after the kidneys that's causing the kidneys to fail. Can you think of an example? How about a kidney stone stuck in the ureter, causing urine to back up into the kidney, which then causes damage? How about a stone in the urethra, causing backup into the bladder, causing backup into the kidney, causing kidney failure? Of these three types of kidney failure, which one do you think we see the most often in acute care? It's a bit of a trick question because it depends where you work. How about on a renal ward? How about on a dialysis unit? For sure, the most common type is going to be intrarenal. This is a chronic problem. The kidneys are permanently damaged or dysfunctional. They need dialysis. How about on just a regular acute medical floor? You might see some people with stones, ureter stone, stones in the urethra or in the ureters. You do. But by far, the most common kidney failure that you're going to see on a generic acute medical ward, even on a surgical ward for sure, the most common renal failure, unless they're a dialysis patient, unless they have kidney disease, is going to be pre-renal. And it's the most easily fixed in most cases. We just have to get them fluids via IV or by mouth. So just digging into some of the details of what I just said, we can look at maps number 1, and you can see all the pre-renal causes up here in these rectangles. What do they all have in common? Decreased blood flow to the kidney. And then, of course, the symptoms and the lab work and the blood work makes sense. We've talked about the rest of this already. All right, intrarenal failure, getting into a little more details. Here's all the things that can cause failure, just a few of them actually, that can cause failure inside of the kidney itself. Okay, don't worry about acute tubular necrosis. We don't need to get into that much detail right now. And finally, post-renal failure. All these can cause that. What do they all have in common? All these causes. Yeah, mechanical obstruction of the urine flow causing reflux and then decreased functioning. A lot of our post-renal failure we fix with surgical, or we just let the stone pass out. A lot of our pre-renal we can fix quickly by giving fluids. It's the intrarenal that usually takes longer by way of antibiotics, maybe surgery, for example, to remove a tumor, and maybe it ends up being a chronic disease. Although pre and post renal failure are easier to treat in most cases and to resolve, they can lead to chronic renal failure, intrarenal failure as well. So question 2 is basically asking us to look at a bunch of common issues that can come up in acute renal failure. Let's look at our concept maps. Concept map number 3 to get a sense of what these are, what causes these things. We just kind of work our way across this concept map here. So we know that the kidneys are responsible for erythropoietin, which is a red blood cell, a hormone that helps to increase the production of red blood cells. So a decrease in that has obvious effects of anemia. Well, if GFR is down, it's pretty hard to produce urine, so there might be a decrease in urine or no urine at all, these terms here. We also know that with GFR, creatininuria rise. Side point that's interesting to note, ammonia, which, you eat protein and then the body synthesizes from that ammonia. The kidneys play a big role, as well as the gut, but they both play a big role in synthesizing ammonia. So this is important. The kidneys have to synthesize ammonia. And then the liver turns it into urea. And then the kidneys excrete urea. So that's how it works normally. The main point for this particular unit being that the kidneys help to synthesize ammonia. Okay, remember that. Let's get into that here. So if the kidneys are failing and one of the side effects is that ammonia is not formed, then we're not able to excrete hydrogen, because hydrogen is something that's excreted with ammonia. You can end up with acidosis. Okay, and if you remember back to unit 1, when you have metabolic acidosis, you have compensatory mechanisms, one of them being that bicarb is created and gets used to buffer the acidotic state. At any point, dialysis may be needed in any of these issues here. Okay, this is just a review of unit 1 here. So you might find an increase in sodium and RBCs and white blood cells in the urine. Why is that? You might find the kidneys dump certain things. This could be some of what they dump. You're also going to find increased concentrations of this because it's forming there's less fluid running through the kidneys. Your serum K may go up with the acidosis. Remember, that can cause K to go up from unit 1. It could also go up because maybe the kidneys are holding on to potassium. It's really hard to predict with the kidneys. These are all possibilities. And then we have to treat how to get rid of all that extra potassium. And these are some ways here. Remember, K-oxalate from unit 1 helps excrete potassium through the feces. And there's some other ways here to deal with the underlying issues. If vitamin D production is down, which again, the kidneys are helpful with that process, then less calcium is absorbed. So you're going to have less calcium in the bloodstream. A big one here that may not be obvious is that at first is that the kidneys, when they're in failure, can alter the white blood cells and their ability to fight infection. And actually, the leading cause of death of infection of kidney disease is infection. One thing here I forgot to mention was the whole thing about the edema. So if the kidneys aren't allowing fluid to kind of filtrate through, then it's very common that that fluid will build up in the body, causing edema. And then the use of diuretics might be needed. It might not work. The only alternative might be dialysis. Okay, finally, just looking at the diuretic phase and the recovery phase of acute renal failure. Just kind of want to do a quick overview of those phases, and I think we'll just go to our concept maps for that. The key points of the diuretic phase are pretty clear in this diagram. The acute renal failure may be starting to resolve. You still have issues with GFR, you still have issues with creatinine and urea, but some waste is being excreted. Lots of fluids are being excreted, so filtrate's getting through, and this is good. GFR will be starting to come up, sure. It will be. So all this fluid's going out, but the kidneys have not yet gained the ability to control how concentrated that is. And so what you end up having is lots of water exiting. You'll have dilute urine, lots of it. You could have up to 5 liters a day coming out. You got to watch your fluid balances, and you got to watch your electrolytes. You could be losing electrolytes in like sodium and K. You could be losing all that in the urine. You could be losing blood volume. So while the kidneys are starting to work again, they're not working incredibly efficiently. And the large water content is coming out. Watch your lights. Watch your fluids. The recovery phase, things are getting better. Lights start to normalize. The concentration of urine becomes more appropriate to what is the norm, and your GFR, creatinine, and urea start to normalize as well. You see these things happen really fast when it's pre-renal failure. Of course, when it's something more serious like intra-renal failure, it can take much longer for these stages to go through.